Great. And guys, you are at the Pioneering Palliative Protocols lecture, Integrating End-of-Life Care into Emergency Medical Services Practices. I'll start by introducing myself, but I want to I'll have my co-lecturers introduce themselves as well. But my name is Satish Ganaga. I am a emergency medicine physician and a clinical research scientist out of Henry Ford Health and Michigan State University Health Sciences. I am a hospice and palliative medicine champion, and I'm a non-boarded EMS physician medical director in Wayne County. So kind of all my passions have aligned here. I have some conflict of interest on a board member for Compassion and Choices, and also some research money I get from NIH and John A. Hartford Foundation. I want to introduce Dr. Amelia Brer.
Hi, I am the EMS Medical Director for the City of San Francisco, and I am a palliative care enthusiast.
And I'm Justin Bruton. I'm an emergency medicine and palliative care physician who actually did do EMS prior to going into residency for about, prior to med school for about 4 years in the Atlanta area. And I'm passionate about working with EMS systems to develop palliative care protocols and best practices for dealing with palliative care and hospice patients.
And I think that's one thing that Justin, myself, and Amelia all have in common is before our medical school journeys, we've all worked the road in some capacity. I worked the road for 6 years on an advanced care life support unit in Washington County. Justin has worked the road, Amelia. So we bring that out of hospital experience along with our ED experience and our palliative medicine championing into this lecture. I want to quickly go over the objectives here for us. Could we make that one bigger? Do you know how to do that? So we could read from it. But essentially the objectives for today, we just want you guys to be familiar with the current literature, which is growing around the intersection of EMS and hospice palliative care. These two communities clearly intersect, but it hasn't been really studied that much, and we don't talk about it that much, both at the out-of-hospital level and the ED level. We're hoping that at the completion of this lecture, you guys will be comfortable recognizing the best components of an EMS hospice palliative care protocol. And what I really want you to leave here at the end is you have 3 people that have gone through the journey of getting these type of protocols approved in their states. We have drafts. We have, I don't want you to have to recreate the wheel if you want to bring this to your state. We will share these resources. In my humble opinion, Justin and Amelia are our leading research experts in the space and the country. And like if you reach out to them, they will help you as they've helped me across the way. So let's start out with a tale of 2 patients.
So I'm going to start with the first one here, a 72-year-old guy who end-stage COPD. He develops respiratory distress due to superimposed pneumonia, and his family calls both hospice, which he's enrolled, and 911. Hospice takes about 30 minutes to arrive, and EMS about 10 minutes. The patient ultimately transported by EMS to the ED. He's transitioned to comfort measures, multiple obstacles to his disposition elsewhere, and the patient ultimately dies in the emergency department.
Contrast that with another patient who's on hospice care. They call hospice, same problem, the time that it's going to take for them to get there, except this agency has orders, standing orders to be able to administer controlled substances and can help get the patient's symptoms stabilized. And that allows some time for the hospice nurse to arrive to kind of mitigate the concerns of the family. And this patient is able to continue to stay at home for his hospice care and dies at home.
So just some grounding definitions here about the difference between palliative care and hospice. Especially for those with an EMS background, this might be a little bit less familiar. So for palliative care, it's really intended for patients with serious life-limiting illness, and the focus is on the quality of life, symptom control, so patients can pursue curative treatment simultaneously to palliative care. And hospice, although kind of overlapping in its philosophy, is really for patients with less than a 6-month life expectancy. And also importantly, it's an insurance status. So each hospice patient gets about $200 a day, the hospice agency, I should say, for the staff, the medications, the equipment, and the services. It's a covered Medicare benefit, which is kind of particularly important when thinking about it from an EMS perspective.
I think this one's me.
Oh, yeah, that's right.
Absolutely.
Sorry.
So it's okay. So I think what's really important too, and I've seen others describe this, palliative is the big umbrella. right? The big umbrella of, the services we can provide patients at end-of-life care. Hospice is specifically one program under the palliative umbrella. But the focus around a lot of the EMS protocols around hospice right now, because those are clearly identified and there's a lot of resources, though we're extending it to the palliative side. What I want you guys to get a feel for is the intersection, okay? I think once you start to understand how often our EMS clinicians and teams are interacting with these patients, you start to get the value for where these protocol development really lies. So it's estimated that our EMS teams will interact with patients at the end of life, hospice and palliative, up to 20 to 80% of every patient that's enrolled in a hospice. These outcomes, these encounters vary from simple falls to other things that we're going to discuss in more detail. But the hospice as a program is growing exponentially in the United States as people and patients and families are deciding they want more say in how they die. They are defining what's most important to them. And often, this is the first time it's happened, but there are more people dying in their homes in America than dying in hospitals now. Okay, that's the first time, ever. And so that type of transition, really represents a culture change. And we got to ask ourselves, where do our EMS partners fit into that culture change? And they definitely do. This is a study that my team did out of the Henry Ford Health System, and it essentially looked at about 6 years of data, 45,000 patients who received hospice or palliative care consults from a Henry Ford hospital, okay, during that period of time. And then we just went back in retrospectively and tried to get a feel, how many touches did this patient group have with EMS? A lot of these patients weren't already on hospice palliative, so keep that on mind, right? This is retrospective, but these are patients at their end of the life. And what we found essentially is that 55% of these patients arrived to the hospital via EMS and 911. 5% of these patients showed up at like a freestanding emergency department and then required interfacility transport to a hospital-based, for inpatient care. And that 44% of these patients actually, if they survived, were discharged home via EMS teams, okay? So you see 3 different types of touches, right, that we need to kind of be considering, but this is a lot of touches. When we really did the math here, what we found is that 75% of this sample had at least 1 EMS touch, with a third of patients having 2 EMS touches during their encounter, and 1%, so 1 in 100 actually had 3 touches. But you could see EMS interacts with this patient population, period. And then, let's really talk about why they start coming to the ED. Why are they calling 911?
So one of the things we've heard so many times is that hospice patient shows up in the emergency room and you can just hear the attendant go, "Why is this patient here?" Right? And there's so many different things that factor into that. Inevitably, the regular caregiver is going to leave the house to go grab groceries or run an errand, and then the neighbor's helping out, and then that person either looks really sick or gets some distress, and what do? They panic. I can tell you, having worked in EMS, having seen some of these situations long before I had the skill set and I understood these things, when you have a patient with lung cancer who starts exsanguinating at the house, you better believe that family's going to be distressed. So there's numerous things that can happen, and the goal is to make protocols that are going to help address those things, because these calls are going to continue to take place. The situations that lead that family or that caregiver to call 911 are going to continue to take place. So you have to build a protocol that's going to allow for that.
And so, I wanted to lead this slide simply out of non-self promotion, but guys, in my humble opinion, this is the most important piece of literature to date in this EMS hospice palliative care space. And it is a joint position statement between the National Association of EMS Physicians, right, our College of EMS Physicians, as well as the American Academy of Hospice and Palliative Medicine. And this group of authors, in my mind, were really forward-thinking, really thought leaders, really outlined where the gaps are, where opportunities live, and I'm just really proud that 2 of those authors are standing right next to me, right? These guys are the thought leaders that are kind of moving this, this literature. But based on that, I actually want Amelia to go over what you guys thought were recommendations for protocols.
I appreciate the hype, as always. And really what that whole position statement is about building bridges. If we can do that between these two giant organizations, NAMSP and AHAPM, like we can do it. So really what that means, how do we build bridges? And this is kind of just a three-step approach. It's about EMS having hospice and palliative protocols, talk a little bit more about kind of what that means, and it's the education component. It's whether you're an EMS medical director, you're a hospice medical director, you're a paramedic, understanding what everyone else does, what resources they provide, so you can make those referrals, so you can make those kind of warm handoffs. And then we'll talk a little bit about being creative, which anyone in EMS knows a lot about. So this is an unpublished review of EMS state and major metropolitan area protocols. And approximately only 20% of states have a hospice protocol for EMS. And only 15% had a palliative or end-of-life protocol. So for a patient population that is commonly encountered by EMS providers, but whose treatment pathways differ significantly from other routine EMS care, there really is just a tremendous opportunity for involvement and really improvement. So kind of launching from that, really encouraging EMS to contact hospice. That's kind of the first part of any EMS protocol is that. The contact, when you contact hospice, hospice knows best, really. The family, they know best kind of treatments and really can maybe potentially intervene. So making that first call as a 911 responder to hospice before transporting can really potentially avert some unnecessary transports. Encouraging the use of hospice emergency kits, that's within the scope of practice. If you're an EMT, you can encourage someone to use their home medication. I'll let Dr. Bruton talk a little bit more about that and how the work he's done. And then lastly, the third kind of component of any good EMS hospice palliative protocol, avoiding naloxone. EMS loves giving naloxone. This is the one patient population where you probably don't want to give naloxone. A lot of these patients are on heavy doses of chronic opioids, and that agonal respirations they're experiencing is probably not from an opioid overdose. It's probably the process of active dying, and precipitating a pain crisis in this patient population is exactly what you want to avoid. So these are really just simple protocols, but compassionate protocols, and it's really just empowering EMS providers to allow a natural death, which just feels really counterintuitive sometimes to a lot of other EMS protocols. Education, emphasizing really everyone should know at least the basics of what everyone else is doing. Paramedics should know what hospice provides, and hospice should know what an EMT versus a paramedic is able to do. I want to emphasize that EMS and hospice are both hyper-local. So this really kind of has to happen at the ground level. As great as it was to kind of create like a national position statement, it has to do with like your local EMS medical director and your local hospice director kind of talking to each other, what medications that they have available on the rigs, what medications they have in the e-kits, and kind of talking that through. And then communication skills training. EMS, so good at procedural skills trainings, intubations, IV lines. Communication skills training needs to be taught the same way, practiced and honed like any other skill. And then I want to emphasize big and small education moments in this space. So there's the big moments. You're rolling out a protocol as an EMS protocol. You want to kind of emphasize the difference between palliative care and hospice to your paramedics and EMTs. Those are kind of the big moments, the core philosophies. But then there's really the small moments, especially when you're an emergency medicine physician. It's those really small moments when a paramedic comes in with a patient who's enrolled in hospice and taking that extra moment to mention, hey, did you happen to contact hospice before you transported them? Well, maybe next time you should. They're a great resource, and kind of doing that politely. Or similarly, that same emergency medicine physician, when you're talking to an EMT who's transporting that hospice patient back home, mentioning maybe you don't need to check those vital signs every 15 minutes, and kind of having those small moments that are moments for education. So I want to talk about being creative too. EMS in particular this is kind of their space, is really kind of thinking outside of the box. There's a role for palliative extubations, allowing MICU patients to transfer home, and this is really something where EMS physicians can be that conduit from the ICU and perform a palliative extubation in the home, because those are the two spaces that they're comfortable with. And then I'll let Dr. Bruton talk a little bit more about community paramedicine.
So community paramedicine is a tremendously helpful resource, and one of the things in talking with other people that work in EMS systems, you have these senior medics that have gotten tired of the gun and knife club, and they have a tremendous skill set, they have experience, they have communication abilities, they're relatable, but they can continue to stay in the field and provide a different kind of guidance for these patients, so they're really good at seeing chronically ill patients and just keeping tabs on them. And one of the things we've trialed in our system is allowing them the ability to make hospice referrals. So they've worked closely with one of our local hospice agencies, because a lot of times they really know these patients well. So you keep their involvement in the system and you utilize their experience and communication abilities to help these other patients. And just like EM physicians have come up to me and said, I transitioned somebody's care and it was really rewarding. These medics that have done all that high level resuscitation and high adrenaline stuff will go, man, it was so rewarding to just help this family when they just needed the guidance and the help to make this transition. So a couple things about how EMS systems can integrate better. So the 911 system itself can be designed to keep tabs on patients who may have advanced directives or maybe current hospice patients. Different systems have various levels of integration into their electronic systems that they use as part of the dispatch process to try to keep track of this. As simple as even like signs or like little flags or things that some systems have employed when there's like a known hospice patient at a house. And then having a mobile integrated health system, this is continuing to expand, but taking these more senior paramedics and giving them maybe some additional education in this realm, or giving them the ability to make hospice referrals can help, and they can identify patients early on that they've had a relationship with that are starting to kind of dwindle and maybe at that place where they're ready for a transition to maybe hospice care. The other thing too, I think EMS in general is realizing, just like EM has realized that the palliative care population is coming to our doorstep, and we're going to need to have the skill set to take care of these folks. The need for patient-centered care, the traditional resuscitate and stabilize, and that's your role, has transitioned to go, there's patients where we need to really think about the role of resuscitation with those patients and the role of intervention with those patients. And I can tell you just from experience, being in a situation where you do not have the skill set to handle that problem is scary, and you feel overwhelmed. So I still remember those situations as I wasn't a paramedic, I was an EMT at the time since I was about to go to medical school, but feeling like I don't have the skills to take care of this, but somebody needs to take care of this, and why aren't the physicians taking care of this? I remember thinking about that when I would transport that chronically ill, contracted person who I knew needed to go to hospice, or that person that was discharged from the hospital that we were trying to drive as fast as we could to get them to the hospice house 3 blocks away before we had to write up the sedent in the back of the truck. So the end-of-life care needs are now being more recognized, and we know it needs to happen. Elements of a hospice protocol that you need to consider. So being able to think about them getting an e-kit and utilize those, utilizing access ports or other means to give medication, avoiding Narcan, as Amelia mentioned before, and having pain management schedules and recommendations that allow for patients with higher pain needs to be escalated quicker. Other means for non-narcotic adjuvants that can be helpful, and being familiar with like baseline dosing, right? Understanding chronic pain patients who are on high levels of medicine are going to need completely different dosing than somebody who's just taken, Oxy 5s a few times a day. In North Carolina, we developed a protocol that is something that if you'd like to see this and like to see what we did, I can give you the website for that. I think we may have it attached at the end.
Yes.
And basically, this has elements that follow an algorithm where the medic can identify those needs, make use of contacting hospice, utilize their orders to give medications to help stabilize the situation and de-escalate it, and then try to avoid transport when appropriate. Because they may call, and if somebody falls and breaks their arm and needs a splint, that may be a reasonable reason to go to the ER. But if it's a pain control issue, or it's the very end of life transition, the family's just distraught, that is something that can be stabilized on the scene.
Yeah, I'll transition here, and look, I want to give real props to that Wake Forest EMS protocol. In my opinion, it is gold standard, and I used it to develop my Michigan EMS hospice protocol, as well as other components from one of Amelia's protocols she developed. you do not need to recreate the wheel. Like, these resources are here. The three of us want to help you guys, if you're EMS leaders or palliative leaders in your space, to develop these protocols. And the other piece, it's one thing to develop the protocol, it's another thing to roll out, an implementation. And implementation takes real educational resources. The good news is these educational resources, some of them exist already. My favorite was created by Amelia and a group of EM doctors around a small grant that they got through ACEP, and it's called the Pre-Hospital Provider's Perspective on Palliative Care. It's essentially 3 modules, approximately 90 minutes, with CME on Prodigy, so it's open access for paramedics. This one could be easily plug and play if you're an EMS medical director, and you could use these as your initial education. Amelia and I are giving a lecture this week for EMS week, and it's a virtual lecture, so if you're interested, please email me and I'll send you that. It's 2-hour lecture, 1 hour kind of that looks like this, and then 1 hour going through line by line the new Michigan EMS hospice palliative care protocol that we just got approved. And so we figure it's gonna take us a minute to educate these crews. Ganaga's gonna go to all these EMS stations and get them hyped up. And we're gonna roll out live in September and try to track it from a quality perspective. There's other resources. Dr. Bruton Justin, he has created a beautiful website called palliem.org. And on that website, and I'll show it to you right here, if you guys wanna take a picture of this one, this is a good one. Multiple QR codes. One goes to the position statement, which you might need to give your EMS medical directors to get them on board, right, if you're a palliative champ. And if you're an EMS medical director, you might need to give this to your palliative, docs to get them on board. The second one is the link to the provider course that I told you that Amelia and her team created. And the third is a link to these beautiful videos that Justin and his team created, where they actually show paramedics taking care of families at the end of life, walking through the wake protocol, how they navigated the protocol, and then even giving some commentaries of education. So if you're an EMS medical director, I don't want you feeling like you got to create all this education. You have champions that are trying to create this education, and there's a group within AGEM that's even working toward improving geriatric EMS care, and I feel like some of these resources can be beneficial to that effort as well. I think we're going to close out here with my boy Justin Bruton.
Yep. So what's important to take away? There's so many. We come from so many different roles, and this is tangible. And I think knowing that there's resources available for those of you that are educators, like this is going to be a key part of those residents that are going to go out in the world and help run EMS systems. It's going to continue to be an issue that they need to have skills for. And if you're running an EMS system, we have resources, and this is something that your crews need help with. It's going to help improve their retention. It's going to help improve their job satisfaction. It's going to help them feel like they're delivering the kind of care that they want. If you're palliative care leaders, so if those of you in the palliative care realm that see these patients that come to the ED and you go, how did they end up in the ED or how did they end up in the hospital? Partnering with others to help have a process like this is in your best interest, because it's going to ultimately help those patients to be able to be managed at home or avoid those last minute transitions to the hospital. And health systems leaders, people are worried about inpatient mortality. They're worried about cost. They're worried about all these other things. It is in their interest to try to make sure that these systems work. One of the things that made our process successful, we had one of our local hospice medical directors. We had our state EMS directors on faculty with us. We had workers in paramedicine and MIH that were on board. I helped come up with our titration medication schedule and recommendations. So really we had all the different pieces at the table, and we all knew it needed to happen. And then we had a group of people that were interested that are like, yes, we want this in our systems. And then like Satish was saying, you go to the actual, like I do in-services at some of our local EMS agencies, and I've got lectures if I'm happy to share, just to say, here, let me make it, this is the physician level content. There's a different level of content we use with them. So thank you for attending, and hope that you found this helpful.
Yep. And then guys, any questions?